Good afternoon, everybody. Welcome to Ken's Counseling Couch. I am your host, Ken Jennings. This is a continuation from the previous stream I did several days ago on the topic of transgender children and medical transition. So, the summary from the previous stream, if you are able to watch it, if you haven't seen it yet, I would highly recommend it. Basically, the stream went into detail on what the current recommendations and standards are as it relates to transgender children and the requirements that are set forth by the professional association that oversees the standards of care for this subject. And it was a very in-depth stream and a very complex stream. Today, I'm here to finish the other part of that. This is going over Arkansas HB1570, which is known as the SAFEACT or the Save Adolescents from Childhood Experimentation Act. Obviously, the name in itself is very controversial. It has a very specific tone that it gives off with it. But regardless of your view or not, your take or not, the goal of this is to go in and look at the bill and look at it in the context of the standards of care we reviewed before. I don't expect it to be a full legal analysis, though I would potentially appreciate any kind of legal input anyone might have, either for or against. I'm going to reach out to Nick from Mercado Law and see if he'd be interested in kind of going in depth on this subject on stream. That would be fantastic. And get his take on it from a legal side, not necessarily the medical or mental health side or the ethics side of it. But like I said, I'm going to pick up on my slideshow that I worked on to be able to present the information, and I'll kind of take it from there and see where the stream goes. I apologize for any noise in the background. It has been raining ridiculous here all fucking day. Pardon my language. And I've done my best to kind of cut the background out, but if it's there, it's there. I apologize. So let's go ahead and get started with it. So let me go ahead and put the slideshow up on stream and make it full screen. All right, so here we have, as I mentioned, the title of this is the Save Adolescents from Childhood Experimentation Act, also known as the SAFE Act. This was passed very recently in the Arkansas legislature. It was not without controversy in both the media and in multiple areas, such as religious organizations, different social support groups, different LGBT groups and their support groups. So you have two sides of a very heated topic trying to address this issue, and in my opinion, it's talking past one another because it doesn't really get to the core of it, because we're missing some of the pieces that matter for some of the pieces that don't. I'll kind of explain that in a little bit. If I don't get to it, someone please remind me, or I'll do a touch up on that as well. So let's go on to the next slide. So this is a bill that was, I believe, passed on the first few days of April, I believe. So let me pull up my little pen here or laser pointer to kind of annotate things. So where are we at here? So let's go down to the section 1. So that's down here. So we're down here. And this is, like I said, the SAFEACT, or the Save Adolescents from Experimentation. And Section 2 here is important, as it states the legislative findings of this act, the goal of it. So, what they found in their research in preparing the law, and so this is their reasoning kind of for why they want to pass this, what their goals in the creation of this bill, the passing of this bill, and getting it through the different chambers in the respective state legislature, and having the Arkansas governor sign off on it. So Section 2, subsection 1. So the General Assembly finds that Arkansas has a compelling government interest in protecting the health and safety of its citizens, especially vulnerable children. So this right here kind of gives you an indication that there's a potential for maybe not having the most neutral approach for it. By definition, is someone who is transgender and a child a vulnerable person? Defined vulnerable. But again, the characterization of it as we move forward, I think is going to kind of give you the expectation of what, the logic behind this was. So, next section. Only a small percentage of the American population experiences distress at identifying with their biological sex. This is true. I will agree with that. You're talking, a very small percentage of the overall population having some form of dysphoria relating to their gender. Again, prevalence and how common it is varies depending on the measure. If you're talking about someone who is trans in general, of course, your numbers may be a little higher. If you're only measuring someone who is transgender and has fully transitioned from male to female or female to male, including genital reassignment surgery, your statistics are going to go way down because that number is significantly less. The treatment of gender dysphoria isn't ironically a binary choice of treatment. You do not have to pick, I'm not going to do anything, or I'm going to go the whole way. In fact, that's not recommended to even suggest that, because that is setting someone up potentially for failure, and it's kind of priming them that the only way they can be okay and that they can be fine is if they go all the way. And some people aren't necessarily comfortable with that, because as we discussed in the first part, part 1 of this episode, there are a lot of things that go into transition. You have somewhat reversible interventions. You have interventions that are fully reversible. You have ones that are irreversible, effectively. So if you tell someone that their only option is, oh, you have to transition, you have to, get, a vagina, or you have to get a penis to be able to be, a true trans person, that's not really the way it works. So you can basically, along the way, find the level of treatment that works best for you. It's no different than tailoring a prescription of a medication. You start at a low dose, you move up until you hit your maximum effective level. And if you no longer need to increase the dosage because you're getting what you need at that level, there's no need to increase the dosage. It can only cause more harm. If you increase someone's dosage, you put them at risk of, potentially overdosing if it's a controlled substance, or something of, significance with the way it impacts the body. Or if it's, a mental health med, specifically, say an antidepressant or an antipsychotic, you have the potential to make things even worse than the reasons they initially started taking the medication. And that is never good. So, and I mention that because, again, we're moving on to the next part here on the subsection B here of the document stating, according to the American Psychiatric Association, for natal adult males, prevalence ranges from 0.005% to 0.014%, and for natal females from 0.002% to 0.003%. So again, using those numbers, and again, I don't know the source for those, depending on what or if it's cited in the document, I will try and pull it up. Those may be a little bit older numbers. I have seen numbers that are a little bit higher. Again, it varies depending on your source, depending on how you're measuring the population. It's no different than any research topic, anything you see in a clinical journal. Is you have to not just read the abstract, which many college students, for example, do, or many people just do. Oh, the abstract says this. But if your methodology was shit and it was constructed horribly, you're not getting anything beneficial out of it. You know, I can make a research paper that says, "Oh, I can prove that you can treat trans with electroshock therapy," and you know that it was a perfect treatment, but only did it to 2 people. But people could then cite my work as saying, "Oh, well, look, and I got it published in some journal somehow." Don't ask how, but it did get published, in the hypothetical. So people now can cite that as a way to bring back electroshock therapy as a way to treat gender dysphoria. Of course, obviously, kind of going to the nth degree there, but the point still stands. So on to the next section. For the small percentage of children who are gender nonconforming or experience distress at identifying with their biological sex, studies consistently demonstrate that the majority come to identify with their biological sex in adolescence or adulthood, thereby rendering most physiological interventions unnecessary. If we go back to the information I cited and we went through on the standards of care, this is actually a very true statement that a lot of children who at some point in their childhood, usually early childhood, who are gender nonconforming or identify as a different gender, will end up moving forward and not having that issue, if you want to call it an issue. But for sake of conversation, we'll call it an issue. They will move forward. They will move past this stage of effectively identity development and move on to whatever they end up, doing with their life. This isn't the issue that overtakes their life. So if we think about that in the way we talked about it before, and, talking about social transition isn't 100%, for the most part, reversible intervention. Not medical, but you can allow that person to give them the experience of living that gender without any medication, without any treatment in that sense, and see if they like what that is for them. See if they feel more comfortable in their identity. And if they don't, then, as that child gets a little bit older, they become more cognizant of the fact that, hey, this isn't who I am. This isn't me. I'm okay with that. I'm just going to go back to being a boy or being a girl. And that is what it is. So again, it's developing yourself and being comfortable with it as you grow. So on to our next line, where we are, number 4 here. So we're now in the number 4. Furthermore, scientific studies show that individuals struggling with distress at identifying with their biological sex often have already experienced psychopathology, which indicates these individuals should be encouraged to seek mental health services to address comorbidities and underlying causes of distress before undertaking any hormonal or surgical intervention. Again, if we go back to the standards of care, this is specifically outlined in that, for the most part, that you can't just push forward on a medical intervention without addressing any of these other underlying pathologies. You have to address the depression. You have to address the anxiety. You have to address anything else that's going on and at least begin working on it. Again, if you're struggling with depression and anxiety relating to your gender, is it going to go away without a treatment, such as social transition or medical transition? Not necessarily. But you need to at least put into place the the support systems and the tools and the techniques to learn to manage your gender, to learn to manage your depression and in the context it is. You know, you don't necessarily have to go from completely depressed to perfect to be able to do any of this. But you have to show that you are at least stable to some degree. That if you're in such a severe state that you're not able to do anything, to you're so depressed you can't do anything, well, you're not in a really state where you can effectively carry out these treatments. you know there's the common thing that people will bring up, for example, in relation to transgender male to female surgeries, is dilation of the neovagina after surgery. In the first weeks and few months after surgery, you have to do semi-frequent to frequent dilations in order to prevent the neovagina from uh, healing over itself. So you're talking quite frequently at the beginning. As time goes on, it becomes less important. And from my last check on the literature, you're down to like maybe once a week on actual needing to do a dilation, and it's like an hour max. Again, depending on your technique, your surgery, how your specific situation's going. But again, this isn't necessarily at odds with the information we went over before. So if we move on to the next part, so that's part 5 here, or subsection 5. Let me see here. So even amongst people who have undergone inpatient gender reassignment procedures, suicide rates, psychiatric morbidities, and mortality rates remain markedly elevated above the background population. There is some truth to this. However, I will take issue with this. There's the common cited 40, 41, 42% statistic of transgender people committing suicide even after having transitioned fully. There is a lot of controversy around that specific study, for example, that's very often cited. And even the study's authors have come out and said that the way that statistic is cited is not necessarily accurate. I don't have it off the top of my head right now. I was a little rushed in getting this stream set up today, and I'm willing to reapproach this in the future if we need to specifically talk about that if it's necessary. I've got no problem with that. But there's nothing necessarily inappropriate about having other issues even after transition, even to the extent of surgery. Gender dysphoria itself is a very complex topic. It is a topic and it is an issue right now that the best way we have to treat it is this process. Is this the way we would like to treat it? Probably not necessarily. There are people I know who are trans who hate having to deal with it. They wish they didn't have to deal with it, that they wish they could just live their life as a male or live their life as a female like they were born. But it's unfortunately not that simple. For those who have tried to do it, it's caused significant depression, significant issues, and it's trying to put off an issue that you can't just do that. It needs to be addressed. You have to focus on it somehow. You have to make progress on it. or it will sit there and you will stew in it and you'll get worse and worse and worse. Just like any type of depression, not even gender related, if it's relationship related, if it's grief related, if it's anything related, if you don't treat it, it will get worse. You can only postpone for a certain amount of time. So, like I said, I'm willing to come back to that. There is an issue with the suicide statistics. I will give that one, and I will make a note right now to come back to that at a later time to talk about suicide statistics on the topic. I might do a short video on that. I've been working on trying to figure out ways to improve my YouTube channel and to try and put out content more frequently because I don't like the lack of content I have right now. So let's see, where are we going to next? So 6A, some healthcare providers are prescribing puberty blocking drugs such as gonadotropin releasing hormone analogs in order to delay the onset or progression of puberty in children who experience distress at identifying with their biological sex. This is true. Again, going back to the first stream, this isn't just you can really walk into a therapist's office first time there, get a letter to go see an endocrinologist, and get hormones. Even as an adult, that's hard. As a child, it's much more difficult. You have to have a lot of things in place, or at least you should be. I will agree, and I do take issue with the fact that there are providers out there, both physicians and mental health clinicians, who are not following the expectations we have set up as a profession to address this. They are allowing politics, their political views, their personal views to prevent them from seeing or enacting the policies as written because they may not agree with them, because they think they're transphobic, for example. They think they're gatekeeping, which is one very controversial topic relating to this. The standards of care as they sit now are not as strict as they were, but are yet still considered gatekeeping by a lot of people in the trans community. I say a lot of people, but honestly, it's not as much. Again, it's the vocal minority who makes the most stink. And that applies to any population, right? Those most vocal are going to be the ones most seen. So they're the ones stating that it's gatekeeping, and they're the ones who are getting heard. The other people aren't getting heard. A lot of it does stem from anyone who speaks up against it does get silenced. I have watched this happen on many occasions, and it personally pisses me off, and it professionally pisses me off because it's preventing us either as a profession or as a society to have legitimate criticisms on this topic. Right now, you cannot have a legitimate criticism on the topic of transgender treatment, on transgender identity, on gender dysphoria, and run against the most far out there shit without being called transphobic, misogynistic, racist, sexist, all of it. You will get criticized to the nth degree. There's a reason I go by the name Ken and I don't use my professional name and my personal name. If I wasn't in a position where I have had people threaten to have my license pulled because I said something they didn't like, I can't lose my way of life just because of that. So I speak out in this way. I give my view in this manner. I don't like it. I wish I could be more open. I wish I could, show myself on stream, show my face. It's not like I'm, you know, in a situation I don't want anyone to see me as far as like a physical concerns, but I have to worry about my family and my career and being able to put food on my table for my family. That's what matters. And the fact that people are going after professionals and regular people who disagree speaks a lot in some cases to the fact that there are controversies around this topic, but we're not allowing it to be spoken up about because we're afraid of hearing the truth in a way. One of my core tenets I have as far as being able to argue your own support and whether or not you support your own views is if you truly are comfortable with your view, you should be able to argue your opponent's view pretty much flawlessly because then you can criticize and you know all the criticisms of your own point of view and you know how to criticize their point of view. So I can argue both for and against this topic. Again, I have my personal views, I have my professional views. I have to split them sometimes. I've sat in counseling sessions, not just on this topic, but on any topic. And I have my personal views and my professional way I have to deal with it. Someone may come in and they may bring up a topic or issue that it hits home for me in not necessarily the best way, and it could bias my treatment against them. In some cases, providers are supposed to reach out to their coworkers, to their supervisors, and say, hey, I may not be the best fit for this because I don't know if I can maintain the objectivity I need to for the position. For example, I'll give a little bit of my personal life for this one. Is my spouse, she had to deal with a lot of issues relating to her parents being on substances all the time. She had to raise her siblings pretty much most of the time, and then the times her mother was home because she had other health issues, she was taking care of her mom. So I take issue with people who are in significant levels of substance abuse and are putting their children in that situation because I've seen personally in my own home, in my own family, in my own life since I've been married to my wife, the issues that come with it. And I know how much damage that causes. And it's different from just seeing it versus living it. So I'm very specific about clients I take on with that because I do not want to put that person into treatment with myself if I'm the wrong person. So I take that shit very seriously. Just like this, I'm able to deal with my personal and professional sides of it. And again, my personal views may more align on some parts of this. My professional views may, support the expectations and standards set forth. I have my disagreements, but I can still do my job. If you're criticizing someone to that extent on this topic, that you're really going after them, that you really don't like the fact that they're speaking out, it really means you're uncomfortable with your own view. You don't have to be solid in it. But if you're uncomfortable with it, you should either A, figure out why you're uncomfortable with it and is your view wrong or did you just not know enough? Or B, maybe your view is wrong. So like how do you, as a person deal with that? Not everyone knows how to, and I think that's part of the problem as well. All right, so we're going on to the next section here. We're on 6B. The prescribing of puberty blocking drugs is being done despite the lack of any long-term longitudinal studies evaluating the risks and benefits of using these drugs for the treatment of such distress or gender transition. This was also mentioned in the standards of care that when the standards of care were written in 2011, which was in the version 7 came out, version 8 is currently in the works and has been for a couple years. I have been trying to get an answer on when there's a potential release date. I don't have it. I have found information regarding what some of the focuses are on the next version. And I can tell you that the information I have found is very in depth on the topic of child and adolescent transition. and medical transitions specifically for adolescents. So, yes, there is some truth to this, right? But does that mean we should be using it to bias ourselves completely against the idea of being able to have any kind of medical treatment, right? So, where do we go next here? So, we're down to number 7. Healthcare providers are also prescribing cross sex hormones for children who experience distress at identifying with their biological sex, despite the fact no randomized clinical trials have been conducted on the efficacy or safety of the use of cross sex hormones in adults or children for the purposes of treating such distress or gender transition. Now, I am a little bit skeptical of this one just off the bat because we have decades of experience on this, on cross sex hormones, at least for adults. One of the reasons you'll also find issues with any research relating to children is doing clinical trials on children 12 and under is incredibly difficult. It's already difficult to do them on anyone under 18 because you need parental consent. You have to go in front of the Institutional Review Board for things involving children that young. And you have to justify and put in place all of these safety precautions to do this kind of research. But when you have, again, we're talking about a population that is low, you're also talking about trying to implement this kind of, you know, trial in a situation where you could have a group of 10 people or a group of a dozen people. Let's assume all the same age. And they will all experience their gender dysphoria differently. And they will all go through the stages of transition differently. Some of them may end up wanting hormones, some of them may not. Some of them may not yet be ready to take hormones because they haven't addressed their other needs. They haven't started working on their depression or their anxiety, for example. Even if you do a longitudinal study and do this over time and you find the people who, okay, this is a 13-year-old, this is a 14-year-old, 15-year-old that, we're doing puberty blockers or we're doing cross-sex hormones, that, you can show the efficacy and the safety of it. You're still talking, it takes a while to do that because the safety and the way we tailor and prescribe these hormones are done very specifically. You're talking about frequent visits to adjust dosages, you know, identifying and managing and any risks or side effects. How do you balance it? And what it means to, you know, is this something where if they're prescribed it, do they need to, for this to be in the eyes of the legislature for this example, right? Because this is the legislature's issue. This is their findings, quote unquote. So if it requires them to have at least a year or more of research and clinical trials of cross sex hormones for children or adolescents, that would be incredibly difficult to produce that. And then, arguing against that point for a minute, right? You do get a study that is able to get a decent enough size of people who are eligible for that and are able to meet it for that time period. It can be easily dismissed by saying, "Oh, your trial population was only a dozen or two. It wasn't hundreds or thousands." But again, we're talking with a very small percentage of the population, which makes all of this very difficult. But just because we're at a current point where we may not have the most in-depth research, we are working on trying to get more data, being able to set safety and efficacy as a primary piece of this. And if we go back to the standards of care from the previous stream, there is a lot of issue with just being able to just, oh, here you go. You get to now have all the hormones and all the puberty blockers. No, it don't work that way. So this can be kind of seen as a way to maybe bias against the idea of, oops, sorry about that. Bias against the idea of being able to actually move forward with anything in this topic region, right? So if we move down to number 8, we're down here now. Oh, that was weird. The use of cross-sex hormones comes with serious known risks such as, so for biological females, we have, second here, uh, erythrocytosis, which is an increase in red blood cells, severe liver dysfunction, coronary artery disease, including heart attacks. And give me 1 second while I move back to my presentation thing here, because I switched off of it to check on comments. We are back up at the top here. So cerebrovascular diseases, including strokes, hypertension, increased risk of breast and uterine cancers, and irreversible infertility. So this section up here and from the previous page is for biological females. This section down here, from here down to basically here, I think, is for biological males. So for biological males, thromboembolic disease, including blood clots, cholelithiasis, including gallstones. Apologize for that. Again, coronary artery disease, including heart attacks. Macroprolactinoma, which is a tumor of the pituitary gland. Cerebrovascular disease, including strokes. Hypertriglyceridemia, which is elevated levels of triglycerides in the blood, breast cancer, and irreversible infertility. This is one of the issues that, and I'll circle it up here too, because why not? That when you have someone who's an adult coming in for transition related treatment, this is something that is discussed very specifically, and there's a reason why the fact that you should take into consideration preserving your sperm or preserving your eggs, because it's not a guarantee you'll be able to have kids in the future if you start to detransition. Assuming no surgery, if you start to detransition, there's no guarantee your eggs or your sperm will be healthy or safe enough to be able to actually have children. And so that is one of the key parts of those pre-hormone prescription counseling, understanding the risks and if you're okay with that, and what it means to have the inability to ever have children biologically. And it's important for young adults and as well as adolescents, that's a big deal, and not a lot of people realize how important that can be. And you'll have at some point in your life that kind of primal urge to want to have a family, to want to raise a family for a lot of people. And then if you do this and then you decide at some point later that I fucked up, you have now not only fucked up, you have fucked up and you didn't prepare by preserving sperm or preserving eggs. So you are not having biological children at that point, unless you've got tons of cash to blow. So we're back down on to number 9. Genital and non-genital gender reassignment surgeries are generally not recommended for children, although evidence indicates referrals for children to have such surgeries are becoming more frequent. This is absolutely not the case. I don't know where they're getting that, but this is not within the standards of care especially as it relates to genital surgeries, right? You cannot have a genital surgery under the age of 18, according to the standards of care set forth by WPATH. Period. That's it. Unless you are of the age of medical consent or an emancipated minor, but even then, you're still probably not likely to do it. I'm pretty sure from the standards of care, you need to be an adult. You have to be an adult. The only real surgery that you can get as a child or adolescent would be breast removal. That only requires one letter from a therapist to be able to have the surgery versus two for a genital surgery. And that really requires either parental consent or age of medical consent, which is anywhere from the age of 14 to 18 based on your state or locality. So, so 10A kind of goes into the details of genital reassignment surgery, which includes several irreversible invasive procedures for males and females, involves alteration of biologically healthy and functional body parts. So, yes, you're removing a body part that doesn't have a specific issue by itself because the body part's not the issue. We're not saying that the penis or the vagina or the breasts or any of that are the issue. It's not that they're diseased and need removed. You are removing it in effectively a way that is a cosmetic surgery, basically, ish. But you're treating a mental health disorder in the process, right? If you had something that was causing an increase in depression or another mental health issue that was treatable with a surgical intervention, then there's ways to, kind of address that. That's not just medication or therapy. It's definitely rare, but they do exist. So, are there situations where you might remove a healthy body part that is causing something like that? I can imagine a few. Again, they would be rare, but it's still something that this characterization right here, I think right here, this characterization is just a way to kind of, it just looks and feels a little bit off to me. And I don't like the way it's going because we've had great parts of this so far that are very specific. They're very sticking to the kind of literature or some of the information that's out there. And then we also have parts that aren't that strong. So, but I digress. So if we move on to what those surgeries involve, so down on part B here, biological male surgery involves genital reconstruction, including a penectomy, which is the removal of the penis, an orchiectomy, which is the removal of the testicles, vaginoplasty, which is the construction of a vagina-like structure, typically through penile inversion procedure. I will add that there are a couple other techniques here, so let me do my own little star. And you can have the creation of the neovagina through a couple other procedures. One of them is through the use of the removal of a section of the sigmoid colon, which is a small piece right after the bend in the colon, after like the rectum in the beginning parts of the anus. Like it's that little part of that turn there. It's called the sigmoid colon. You can remove a section of that and you can use that to construct the neovagina. One of the interesting, if you find it interesting or not, aspects of that is using that because the colon and the tissue that are related to the colon to help keep from having, you know, your bowel movements and your stool back up, your colon lubricates itself. So the neovagina using a sigmoid colon procedure can self-lubricate. There are mixed reports about the smell associated with it. Some people complain of an issue with smell, some don't. But there's also people who have complaints with the smell regardless of the technique used. But just a fun little fact there. I know someone's probably going to hate me for giving you that information, but oh well. Also, we have a clitoroplasty, which is the construction of a clitoris-like structure. So if you're not too familiar with the penis or the way that the male and female bodies are formed in early parts of pregnancy, a lot of your genital parts can kind of come from the same initial parts of the cells. And so the clitoris and the penis, the head of the penis, are very similar as far as the level of sensitivity. They both kind of come from the same physical structures. That's part of the early fetal development. Again, they move to their separate pieces depending on the level of hormones that the fetus is exposed to. One of the theories behind the concept and idea of gender dysphoria and the issues relating to being trans, of why you can have that disconnect of this is my physical body, but my brain isn't there as much as you may try to wish it, is a variation or different types of levels of hormones that a fetus is exposed to at certain points in pregnancy. Again, it's not hard to find yet. There has been some research on it, but it is an interesting thought that you can have different levels of hormone development change who you really are. That your body can be 100% different than what you feel and who you are in your head, in your personality, in your core, based on some simple fluctuations of hormones at some stages when your mom was pregnant, or because maybe mom was taking a certain medication, or maybe something was interfering with her hormone level. She was sick. She had something else going on. We don't know that you could now possibly have to deal with this at some point in your life. This will become an issue. To me, I think it's just an interesting concept. Uh, so again, we still have one more thing. So we have a vulvoplasty here, which is the construction of a vulva-like structure for male to female transgender persons. So down here for biological females, surgeries involve a hysterectomy or oophorectomy. But just give me 1 second here. I need to move to the next page. Reconstruction of the urethra, general reconstruction, including metoidioplasty or phalloplasty, which is the construction of a penis-like structure. Now, as I mentioned on the previous stream, the level of skills and detail we have at constructing a neovagina for trans women is much more advanced than the skills and techniques we have in place for transgender men. Like I mentioned in the last show, lots of the techniques that are used for this are taken from the recreation of the vagina for women who have suffered traumatic injury to their genitals because of something happening to them. And so that's why we have decades of being able to do this versus the level of detail and specifics we have on this is still growing to be able to do the creation of a penis on a transgender male. One of the techniques does not create a functional penis for intercourse. It's just there is like a flaccid penis. There is a method to create a functional sexual organ for penetration, is it actually involves using effectively a pump that you it's they put basically a air pump sort of in the testicles that allows you to pump up and inflate the penis. That's, skin and everything, so it looks like a penis. It inflates, allows you to do penetrative intercourse, and then you're able to deflate it basically afterwards. Again, the techniques are still growing. They're nowhere near as good as we have for the other transgender women, as I mentioned. So it's a process and development, regardless of your um, view on the topic. Just the ability to do this is kind of interesting in and of itself. So we also have a vaginectomy, which is removal of the vagina, the scrotoplasty, which is creation of a penis-like and scrotum-like structure. Also, kind of back on that point, we have the creation of uh, the neopenis is used from either you'll get like they'll cut like a flap of skin off of your arm or thigh, depending on the level, how much skin you need for that creation. I think I went forward one. There we go. I went forward 2 slides. My bad. Okay, so next part is implantation, erection, or testicular prosthesis, as I mentioned. Number 11. So we're down to number 11. The complications, risks, and long-term care concerns associated with genital gender reassignment surgery for both males and females are numerous and complex. I would agree with that. Non-genital gender reassignment surgery includes various invasive procedures for males and females, and also, God damn it, and also includes or involves the alteration or removal of biologically normal or functional male body or functional body parts. Again, this is coming back to that uh, biologically normal and functional body parts statement again. The way, again, the phrasing in it, I feel like it's kind of biasing the person's reading this going in, because it gets you set up to the mindset of, oh, well, their body parts are fine, so why would you ever need to remove them? Again, the issue is not necessarily about the body parts themselves. There's not really an argument that the body parts themselves are the problem. But so for biological males, the surgery may involve augmentation and mammoplasty, so breast implants, which, for under 18, that would be one of the surgeries you could get, would be, breast implants. Facial feminization surgery, liposuction, lipofilling, voice surgery, thyroid cartilage reduction, gluteal augmentation, hair reconstruction, and other aesthetic procedures, which, in the scope of things, a lot of these aren't necessarily, the most damaging should you decide to reverse, right? So, where is that? So, liposuction and lipofilling, you can always flip those. Um, thyroid cartilage reduction, so removing your Adam's apple. They shave your Adam's apple down basically, so it's not as present if you have a very prominent one. Let's see here. Hair reconstruction, so if you're balding or if you have hair issues, to help you, with hair prosthesis, so you grow your own hair. You kind of would end up on the upside for that anyway. Other aesthetic procedures, normally this would involve things like laser hair removal or electrolysis, because you have to have that done at least to the genital area before the surgery, because if you don't, then you'll have issues with hair growing inside the neovagina. Yes, it can happen if you don't properly treat that. As weird as that sounds. Let's see here. What are you wanting there, Magnus? Are you talking about coming on stream? Or are you in stream chat? I'm trying to balance Discord and uh, everything else at once. So give me 1 second while I pull up my stuff here. Or you mean the Mario Kart thing? I'm trying to understand here. Sorry for any digression here. While I wait for Magnus to get back to me, I will continue. So, also, thank you for that, Pepsi Man. This is a new laptop I got a couple months ago. I convinced my wife that I needed a new laptop for work, which I did, and I went ahead and got a nice gaming laptop. It was a nice, pretty penny, but it's worth it. Uh, One of the nice features that's been helpful for me is the fact that it has an RTX graphics card, so I can use NVIDIA Broadcast, which is the RTX voice thing, so I can help reduce background noise when I'm using my microphone. That plus my new fancy microphone I'm using now, which for its price, I'm actually very happy with its quality. And Potato Microphone has officially been retired. For those of you who don't know the lore on that, I'm sure someone will fill you in. What's up, Magnus? I am reading you in chat right now. Did you send me a message? Am I missing that? Sorry, as I try to balance this. Say I'm trying not to. Hold on 1 second. I'm gonna pull my screen off real quick so I don't accidentally dox myself while I try to juggle something here real quick. All right. Pardon any delays. Okay, well, I'm gonna continue while we wait for Magnus to give me an answer here. I am keeping an eye out on both my chats, and I'm gonna see if I can split my screen here while I do the presentation so I can also keep an eye on all the things, which I'm not necessarily the most advanced at trying to balance shit, but I'm doing the best I can. So, the one time where my issue with uh, hyperfocus and multitasking is failing me today. So, let's move on to biological females. So, down here, I know everyone has some. I know, for example, that biological females and the issue on transition related to them has been a lot more controversial, and you see a lot more people who speak out about that and who take issue with it because it gets framed as, you know, young girls or little girls who are doing X, Y, and Z and who are permanently ruining their bodies, and so it gets kind of framed that way, so it can come off, you know, in kind of a there's a moral argument to it, and it also appeals to that because a lot of people will take interest in that, is specifically the fact that, you know, they care a little bit more about their daughters permanently removing their ability to be able to carry a child. It can have a little bit more social impact and societal impact depending on where you live, how people deal with that versus, you know, other people and how they respond to that, because for male to female, the issues just aren't as strongly argued. If you go to a lot of the politicians and people speaking out against transgender, related care for children and young adolescents, you'll see it's more relating to the talk about young girls versus young boys. You'll see both, but you'll see a lot more of the emotional pull on the topic of my daughter or this and that because of what their the purpose of that argument is. All right, so where are we at? So we're like I said, we're on the biological female section. So the surgeries would involve a subcutaneous mastectomy, voice surgery, liposuction, lipofilling, pectoral implants. So that one would be kind of, not only would you remove the breast, but you would do implants there, give you kind of some nice pecs. Um, Guys, also, if you feel like you're lacking in that area, that's something you could also look into. And other aesthetic procedures, so down to 13A, it is an accepted principle of economics and public policy that when a service or product is subsidized or reimbursed, demand for that service or product is increased. Okay, I'm interested to see where this goes. Between 2015 and 2016, gender reassignment surgeries increased by nearly 20% in the United States. Okay, so just because a product is more wanted and more needed, if we go back to this, yes, if it's subsidized or reimbursed. So, with the passage of a lot of laws and a lot of regulations recently, uh, a lot more health insurance companies cover transgender care. You also have, I believe, Medicaid or Medicare also has to cover a lot of transition related care, if not all of it. I know for a fact TRICARE will cover hormones and will cover some other things, but they won't cover at this point surgeries. The same for the VA. The VA won't cover surgeries. They'll cover a lot of the other transition related care. There was an issue, or at least a proposed regulation that was set up for potentially the VA at least to allow for genital reassignment surgery or reconstruction surgery for veterans. Uh, it never moved farther than the steps it was in, and so that never really got answered. You might see that come back up in the very near future, depending on the current administration and how they would like to pursue that, because it was a very big issue relating to transgender issues and topics of politics. So that might get to the forefront in the very near future. So keep an eye out for that. So if we go to 14 here, it is of grave concern to the General Assembly and the medical community, or that the medical community is allowing individuals who experience distress at identifying with their biological sex to be subjects of irreversible and drastic non-genital gender reassignment surgery and irreversible permanently sterilizing genital reassignment surgery, despite the lack of studies showing the benefits of such extreme interventions outweighing the risks, and the risk of gender transition procedures far outweigh any benefit at this stage of clinical study on these procedures. So, I'm going to disagree with parts of this here. So, yes, you can have, as I said, some non genital reassignment surgery for adolescents, very specific groups of adolescents, under very specific conditions. Permanent gender reassignment surgery is not happening and cannot happen under the way the expectations and standards of care are set up. Pretty much anyone who would try and do that would probably end up in a world of fucking hurt ethically and lawsuits, because there's just so much you're putting on the line when you're deciding to go against the standards that are set forth. Again, you will have unique cases where the benefit may outweigh the risks, and so that's why you go forward with it. But in general, I would say that this issue that we're speaking of here, of there being this immediate risk because of so many people now wanting surgery, and that there's such an increase that we must implement a law like this. I feel like it's more a fear-based addressing of the issue than an actual medical, mental health, and logical approach to the issue. So we are coming down to the next section. So we're talking about how we're amending the code. And so subchapter 15 is now the Save Arkansas or Arkansas Save Adolescents from Experimentation Act. So we're getting into the definitions. So this is always going to be important for anything. And I might see if I can pull up the other document that has some of the similar definitions in it, depending on how much these stick out. I only had skimmed through this. I hadn't really dug through it. But if anything sticks out that's clearly not in line with the expectations of like the standards of care, I think I will pull them up for comparison. So definitions. So biological sex means the biological indication of male and female in the context of reproductive potential or capacity, such as sex chromosomes, naturally occurring sex hormones, gonads, and non-ambiguous internal and external genitalia present at birth, without regard to an individual's psychological, chosen, or subjective experience of gender. All in all, for biological sex, probably not a bad definition. I've seen worse. Cross-sex hormones means testosterone or other androgens given to biological females in amounts that are larger or more potent than would normally occur naturally in healthy biological sex females, and estrogen given to biological males in amounts that are larger or more potent than would normally occur naturally in healthy biological sex males. Gender means the psychological, behavioral, social, and cultural aspects of being male or female. This is actually a pretty good definition of gender. I'll give them that much. Gender reassignment surgery means any medical or surgical service that seeks to surgically alter or remove healthy physical or anatomical characteristics or features that are typical for the individual's biological sex in order to instill or create physiological or anatomical characteristics that resemble a sex different from the individual's biological sex, including, without limitation, genital or non-genital gender reassignment surgery performed for the purpose of assisting an individual with gender transition. That would fit that definition pretty well. I think that's a pretty accurate definition. Gender transition means the process in which a person goes from identifying with and living as a gender that corresponds to his or her biological sex to identifying with and living as a gender different from his or her biological sex, and may involve social, legal, or physical changes. Gender transition procedures means any medical or surgical service, including without limitation physician services, inpatient and outpatient hospital services, or prescribed drugs related to gender transition that seeks to alter or remove physical or anatomical characteristics or features that are typical for the individual's biological sex, or instill or create physiological or anatomical characteristics that resemble a sex different from the individual's biological sex, including without limitation medical services that provide puberty-blocking drugs, cross-sex hormones, or other mechanisms to promote the development of feminizing or masculizing features in the opposite biological sex, or genital or non-genital gender reassignment surgery performed for the purpose of assisting an individual with a gender transition. Now, I'm going to take issue probably with this section here in a little bit because of the likelihood that the way that they're going to use gender transition procedures and how they prevent the use of them in this law will mean that it's going to significantly limit the ability to do any of this stuff. And there are currently a good chunk of some of this is still good stuff. It's not permanently damaging, and it doesn't, it's basically reversible, or the risk of harm is little, such as puberty blocking drugs. That is one that is likely to have a better outcome in certain cases for someone who is experiencing severe dysphoria. That because the fear, for example, of the onset of puberty or the beginnings of puberty and their desire to transition to the other gender, as we saw in the standards of care, once you hit adolescence, you're more likely to solidify with your gender. If you're that gender that you're identifying with, you're likely going to lean more towards that gender anyway. You're not going to be like the children under that who may 85% or so, re-identify or end up not having the issue of their gender identity. So I'm going to make that a little note over here. So B, gender transition procedures do not include services to persons born with a medically verifiable disorder of sex development, including a person with biological sex characteristics that are irresolvably ambiguous, such as those born with the 46XX chromosomes with virilization, 46XY chromosomes with undervirilization, or having both ovarian and testicular tissue. So these would be intersex persons. So people, the old term was hermaphrodite, some form of that. Not necessarily a true hermaphrodite, but someone who's not really fitting on the X or Y of, the XX or the XY in the typical sense of you're a boy or you're a girl. These are what your genitals will look like either way. You're talking about a lot more complex things involving these disorders. I don't have anything set aside right now to actually kind of go through them, but they might be something I go over in the future because they are kind of interesting when you look at it, because it does matter kind of in relation to the idea of gender transition. So section 2 here, or II, services provided when a physician has otherwise diagnosed a disorder of sexual development that the physician has determined through genetic or biochemical testing that the person does not have normal sex chromosome structure, sex steroid hormone production, or sex steroid hormone action. So this might be interesting too. III, the treatment of any infection, injury, disease, disorder that has been caused by or exacerbated by the performance of a gender transition procedures, whether or not the gender transition procedure was performed in accordance with state or federal law, or whether or not funding for the gender transition procedure is permissible under the subchapter. So basically, they're saying you can treat any infection, injury, disease, or disorder that might have been associated with the fact that you're having or had genital reassignment surgery or genital transition procedure. So they're not making it illegal for you to fix any of the issues related to it. Next one, any procedure undertaken because the individual suffers a physical disorder, physical injury, or physical illness that would, as certifiable by a physician, place the individual in imminent danger of death or impairment of major bodily function unless the surgery is performed. So number 7, genital gender reassignment surgery means a medical procedure performed for the purpose of assisting an individual with a gender transition, including without limitation. And again, we're going to basically be rehashing some of the stuff we talked about earlier in the definitions and in the findings they had leading up to this. Surgical procedures such as venectomy, all that stuff. I'm not going to go through all of it. Reconstruction of fixed parts of the urethra, phalloplasty. So basically setting forth what the reassignment surgery is for genital gender reassignment surgery. Here's probably going to be an important one. So, healthcare professional. So, a person who is licensed, certified, or otherwise authorized by the laws of this state to administer healthcare in the ordinary course of practice in his or her profession. So, that'll be interesting whether or not they apply that to therapists or counselors, because technically you fall under the title of a healthcare professional in some cases. If you work in a hospital, you're falling under the title of a healthcare professional. Even if you run your own clinic, you're probably going to fall under the title of a healthcare professional. You bill through healthcare insurance. You're falling underneath of that definition. Number 9, non-genital gender reassignment surgery means medical procedures performed for the purpose of assisting an individual with a gender transition, including without limitation. Basically, all the shit that's not fucking with your genitals. Physician means a person who is licensed to practice medicine in the state. Clear enough. Puberty blocking drugs means gonadotropin releasing hormone analogs or other synthetic drugs used in the biological males to stop luteinizing hormone secretion, and therefore testosterone secretion, or synthetic drugs used in a biological female, which stops the production of estrogen or progesterone, which is used to delay or suppress pubertal development in children for the purpose of assisting an individual with a gender transition. So basically, anything that would reduce or stop the ability for the onset of puberty or for puberty to continue. Public funds means state, county, or local government money. Okay, fair enough. Or money appropriated. All right, so I think we're finally getting into the law. Of a 10-page document, we're on page 8 to finally get into the law. So, starting here, line 12, this one. Prohibition of gender transition procedures for minors. A physician or health care provider shall not provide gender transition procedures to any individual under 18 years of age. Okay, so this is any gender transition procedure. So this doesn't specify genital or non-genital. It just says gender transition procedure, which in the previous pages lumped them all together in that specific definition. B, a physician or other healthcare professional shall not refer any individual under 18 years of age, to any healthcare professional for gender transition procedures. So like I said, a physician or other healthcare professional. So that could possibly mean if I were to refer a client to an endocrinologist to be evaluated for puberty suppressing drugs to be able to put off puberty for a period of time so they can make a decision on the determination of their gender. They've met all the other criteria. This is now prohibited underneath this law, under Section B here. C, a physician or other healthcare professional is not prohibited from providing any of the following procedures, which are not gender transition procedures, to an individual under 18 years of age. So you can still give treatment for these procedures, is what Section C here is saying. So services to a person born with a medically verifiable disorder of sex development. We went into those already. Services provided when a physician has otherwise diagnosed a disorder of sexual development that the physician has determined through genetic. Okay, we went through that already. So basically anything not related to gender transition, gender dysphoria, any of the like, or fixing anything related to fucking up or issues related to having had a gender transition procedure. Number 4, any procedure undertaken because the individual suffers from a physical disorder, physical injury. Okay, we discussed that in the definitions. You're not prevented from doing that. Next section here is, I don't know why the pen keeps doing that. It's driving me nuts. Prohibition on use of public funds for gender transition procedures. A, public funds shall not be directly or indirectly used, granted, paid, or distributed to any entity, organization, or individual that provides gender transition procedures to an individual under 18 years of age. Okay, so you're not getting any public money. So if your health insurance is subsidized through the government, through say Obamacare/healthcare.gov, you cannot have gender transition procedures paid for through that. But as we see, it's already prevented because of the prohibition in the law anyway. So B, healthcare services furnished in the following situation shall not include gender transition procedures to an individual under 18 years of age. So one thing that this law basically does is it sets the expectation that in the state of Arkansas now, the age of medical consent is now 18 years of age relating to this issue. So you could be 16, 17 years old and say even emancipated. You have been legally emancipated by the court. You're out on your own. You do not require parental consent for a goddamn thing anymore. You are still prevented by law from getting any of this treatment. And using the example of, say, assuming you're a stable person, you have met the requirements under all of the necessary standards of care. You're being under treatment of a psychologist, psychiatrist, therapist, whatever. You are not able to get the care because they have set a different level of medical consent for this specific topic. Now, I'm curious to know what the age of medical consent in Arkansas is in general. I don't recall it off the top of my head. I'm going to see if I can find it while I go through the rest of this. So the next part is, let's see here. All right, so healthcare services. So by any healthcare facility owned by the state or a county or local government, by a physician or other healthcare professional employed by a state or county or local government. Any amount paid by an individual or entity during a taxable year for provision of gender transition procedures as a premium for healthcare coverage that includes coverage for gender transition procedures is not tax deductible. So you can't even deduct it off your taxes. And I don't know if that would apply to use of that out of the state or not. That would be weird. Again, I don't know if Arkansas has state taxes or not. I love states that don't have state taxes because they're superior in my opinion. That's why I live in one. So give me 1 second here while I look at something. All right, and so we have here too, the Arkansas Medicaid program shall not reimburse or provide coverage for gender transition procedures to an individual under 18 years of age. So right there, this program is preventing any. So if you have that, you cannot do it. You cannot get help through Medicaid for this if you're under 18. So now we're down to enforcement. Oh, God damn it. Go back. All right, so we're at enforcement now. Any referral for or provision of a gender transition procedure to an individual under 18 years of age is unprofessional conduct and is subject to discipline by the appropriate licensing entity or disciplinary review board with competent jurisdiction in this state. B, a person may assert an actual or threatened violation of this subchapter as a claim or defense in a judicial or administrative proceeding and obtain compensatory damages, injunctive relief, or declaratory relief, or any other appropriate relief. C1, a person shall bring a claim for a violation of this subchapter no later than 2 years after the day the cause of action accrues. So that's like a medical malpractice limitation. That's not uncommon. So 2, an individual under 18 years of age may bring an action throughout their minority, through a parent or next friend, and may bring an action in their own name upon reaching the age of majority any time from that point until 20 years after reaching the age of majority. Wow. That's pretty substantial there. Notwithstanding any other provisions of law, an action under this subchapter may be commenced and relief may be granted in a judicial proceeding without regard to whether the person commencing the action has sought or exhausted available administrative remedies. Okay? And any action or proceeding to enforce a provision of this subchapter. A prevailing party who establishes a violation of this subchapter shall recover reasonable attorney's fees. Okay, that's not necessarily the worst thing, but I would be curious to see where other parts of state law have that as well. And so, next part, the Attorney General may bring an action to enforce compliance with this subchapter. This subchapter does not deny, impair, or otherwise affect any right or authority of the Attorney General, State of Arkansas, or any agency, officer, or employee of the state acting under any law other than this subchapter to institute or intervene in any proceeding. Okay. Section 4 is amended to read insurance coverage of gender position for procedures for minors is prohibited as used in this subsection. Gender transition means the same as defined earlier. Health benefit plan, okay, and I think that's the entire bill as it is laid forth that I was able to access and get from the state. Also, one thing that is not in this presentation, which I should have added kind of as an afterthought, was the fact that this law had a proposed amendment to actually provide a criminal punishment for the fact that you would be one of those healthcare providers or a physician and be able to actually get the person a criminal sanction, not just a civil procedure. Versus, like the remote, you can be brought before a licensing board. You can be brought up in a civil suit. But this one, they decided to, thankfully, because of all the ways you could approach this, that's pretty fucking significant. I know that the amendment it failed, obviously, but I think I can access the amendment here. Because there was two amendments proposed. Both of them were in the House. Both were sponsored by the same representative. The representative's name was Lundstrom. Also, yes, I did see you, to Cairo89. How you doing today? Thank you for stopping by. Also, thanks to everyone for stopping by. Pepsi Man Twisted. We've got Anonymity T2, Pixlexia, Pepsi Man, Magnus. Thank you, everybody, for stopping in today. I appreciate people willing to take the time out of their day to join in on these. I know I'm new to this. I know I'm probably not doing this in the best possible ways, but I enjoy it. I'm hoping to be able to do this more and more. I'm doing my best to carve out time to be able to do this, at least do shorter content if I can't do streams. Because obviously, this stream is almost an hour and a half already. And I went through 10 pages of a bill on this topic. I put together, I don't even remember how many slides I had on my PowerPoint. I think it was 37 slides on my PowerPoint. And I was able to get through the other ones kind of fast. But this one, because of all the legalese, took a little bit longer. Okay. Does it not show? Oh, here we go. I think I found the amended version. Or wait, is that not the actual amended version? Now, there is another state's potential. Let's see here. I'm trying to find it. There's another state that is also looking at doing this as well. South Dakota, believe it or not, is trying to pass a bill to do the same thing. Now, I may have mixed up the criminal punishment with Arkansas versus South Dakota. Actually, thinking about it now, I'm pretty sure it was South Dakota. They were the ones that did push forward the criminal punishments with their version of the bill. All right, so let's see here. Let me see if I can find a copy of this real quick, because there we go. Give me 1 second while I skim through this. Um, okay, yeah, it looks like the bill for South Dakota was actually written up to uh, to include the penalty, the criminal penalty. And I think the way it ended up working out is they passed the amendment that removed the criminal penalty. And then the law is currently, as of the 10th of February, it was deferred to the 41st legislative day. And there's been no activity since then. I've been trying to keep an eye on this because I have a feeling that this is going to come up again, and it's going to possibly become another controversial topic. Obviously, it's not um, as simple as some people make it out to be. It is a very, again, controversial issue. You're talking about, in essence, this is a different standard than some people get for other care as a minor. You can have a, you know, I think in, because these different levels of medical consent, do you consider that equal? Can a 14-year-old girl, for example, be able to get an abortion with no consent from a parent, with no other involvement, but yet you have a situation where you have a person, you have a client or a patient who, through not only a counselor or a therapist, you have an endocrinologist involved, you have all these people who are along the way determining whether or not this person meets their criteria for a treatment. They are being given a different standard of care than someone who is simply trying to get an abortion, who, depending on your state, you can basically get done in a couple days, depending on if you have like a 1, 2, or 3 day waiting period. All you need to do is get taken into a room, they explain the procedure to you, and you answer a few questions that some states mandate you to have asked to you, wait a day, come back, and you're done. Versus going through a months or years long process in certain cases to be able to meet the expectations, to be able to meet the requirements to get the care, yet be denied the care that would be most beneficial to you. Again, I'm not arguing one way or the other on this. I'm not saying that kids should get unfettered access to transition related medical care, that they should be getting hormone blockers and hormones and all this surgery before reaching the age of 18. No. But if someone is able to meet those criteria and have the necessary steps be taken along the way, and they're suffering from dysphoria that's causing them distress, that's impacting their mental health. And this is a treatment that is the gold standard in treating gender dysphoria is transition. That's what it is. It's unethical to do any kind of conversion therapy or related treatment. You can't do that. This is the best care you can offer to a gender dysphoric client who is shown to exhibit those symptoms. But what do you do at that point? Is it fair to deny that person care when you could potentially make their situation worse? You could increase their dysphoria. You could make their level of depression, anxiety, increase their possibility for suicidal ideations because you're denying them access to healthcare, even though they are going through the proper steps. This is kind of going to similar arguments on different topics. For example, guns. Do we let the few spoil it for the rest? Do we let the few physicians and the few healthcare professionals who are jumping over the standards of care set in place such a restriction that anyone who lives in this state now is not able to get the necessary health care they need? And you will potentially screw up their ability to have the care they need. Because if that now, say someone's 13, 14 years old, early-ish stages of puberty, call it 10 or 2, maybe 10 or 3, great stage to potentially start puberty blockers, assuming they meet all the criteria. You've now passed this law. They are now going to be forced to go through an entire puberty. They have shown the ability to meet the criteria. Obviously, this is an important step in their transition, and yet you're taking it away from them. Is that right? Is that fair? Say, I think that is something to factor into the overall picture here. Again, I'm not saying right or wrong. I'm not saying one way or the other. But I do think that it's not as black and white as it is to most people. I don't know if anyone is watching at the moment has any comments or if they have any thoughts on that, or if anyone would like to jump in and contribute to that. I'm open to any of that. But like I said, my goal here was to kind of get not only the standards of care out there, because I know for a fact that is not shared enough and not enough people know about it to be able to actually understand the true expectations on what it means for transition related care. And I believe my presentation, we went through the diagnostics on being able to be diagnosed with being transgender. Let me skim back through my. Yes, I did include the links from the DSM. I did include information from the DSM. Also, Keck, I don't know why they have unsubbed you. That is bullshit. I am a small growing channel. I need all the subs I can get. So fuck you, YouTube, as much as I love your platform. Again, I apologize for not being able to make this all one show as I had attempted to initially. I had something come up kind of last minute that kind of made me have to stop suddenly. I'm trying to send a link out to a couple people who are potentially pop onto stream here. All right, so I've got Keck in the waiting room here. I'm going to bring Keck 7 Go on the stream. Keck was on my very first stream on the episode 1 stream on depression. He has been very helpful in a couple different regards to getting me into this process. And he was able to provide a lot of helpful insight on depression and on suicide. So I'm going to bring Keck in. I think Keck has some interesting comments to talk about relating to this. So let me bring you in, Keck. Can you hear me, Keck?
Yeah, I can hear you. Can you hear me?
Yes. Say,
What? Wonderful.
how are you doing today?
I'm doing good.
So have you been able to, have you have a rough idea of what the topic about today's discussion is?
I would assume it's about the related to the Georgia trans law that bans transitional treatment of minors, something like
It
that.
was Arkansas, but
Uh,
yes, it's on that. So my previous stream I did a couple days ago, it was the part 1. This is part 2 because I had to stop early in my previous stream. Was going through the standards of care that are set forth by the World Professional Association for Transgender Health. Uh, I also went through the DSM-5 requirements for the diagnosis of gender dysphoria for children and adolescents. And we just today went through the the law that passed in Arkansas relating to care for transgender minors.
yeah, Finland actually has something similar. It's currently is illegal for trans people to or to have autonomy over their gender and to get into such treatments if they are minor, if that makes sense. So it's essentially like Finland is Arkansas after that law.
So, what
So
age does Finland cut it off at? Like, do you have to be 18 or can you be like
18, yes.
16?
I can give you a link where you can read. I know it's in my funny moon language, but the English translation, as I look at it uh, currently, if you just use the translate to English function of your browser, you can read it.
Yeah, let me see what this pops up real quick.
So this is a
So,
website for the Finnish LGBTQ organization, the main one, SETA. Currently, in Finland, we have a process where people can submit a law for the government to work on if they get enough signatures for it. I believe it's 50,000 signatures that they need to get a law on the table. And so there's currently going into the government a law that would quote unquote correct this wrong where minorities are unable to get into reconstructive surgery, get into medical treatment and all that.
and one of the things that I've ran into in my not only professional but in some personal aspects as well is there's a lot of people who will argue that even in the United States, the you know, even though WPATH, the standards of care, is kind of a worldwide thing, and a lot of countries use it, they I don't know if necessarily all of them kind of take it to be, but I know there's an argument from a lot of LGBT people and groups who will say that the fact that you need a letter from a therapist is gatekeeping. That you should, because before you used to have in the old standards of care, there was a certain amount of time of therapy you needed before you could actually move forward and get like hormones. Now that's not the case. It's just you need to have a letter from a therapist or a counselor. It doesn't say how long you need to see them for. It just says that you need to be assessed and evaluated, but there's no time requirement. So that does come up to professional judgment. Do I think you can ethically assess and evaluate someone regardless of age for hormones in a session or two? If I haven't met them, no. If they're, a client of mine, then hopefully I would be able to see them more than once or twice. You need at least 6 months of this type of issue of having dysphoria to be diagnosed with it, to have these symptoms, to be able to show that there's this incongruence with your sex and your gender, that they are different, that they don't match up, that it causes you shit like depression, anxiety, uh, even other things. But, you have that in place, but, and I believe that the way the standards of care are written, it's a balance of being able to have access to care while also trying to balance people from accessing care too quickly, because there is the downside to have, if you get access to the healthcare too quickly, if you jump from who you are today to trying to get surgery as soon as possible to starting hormones next month, do you really understand what's going on? Do you really understand the differences that's going to change in your life? Because the fact of being trans and having to go through any part of transition that's not just social, any medical parts of transition have a huge impact on your life. For example, just puberty blockers, which lowest risk medical transition piece you can do. You're still talking about potentially delaying your puberty for years, depending on whether or not you decide to, stay your gender or decide to switch genders. You could potentially delay it for years while you make that decision. So you could be starting the delay at 12 or 13, maybe 14, and you don't pick that back up until you're 18 or 19 after you're old enough to decide whether you would want surgery. So you're talking about being a lot different physically from people your age if you decide to, stay your current gender. That'll have a huge social impact. So is it right to keep people from getting quick access to it or not? Should we allow people to be able to have access without all these other steps in the way?
Like I told you earlier, it's this is very hard case by case basis thing because there are absolutely people who would benefit from puberty blockers early on in their life, but there's also a lot of harm that can come to people who go into puberty blockers under wrong diagnosis, for lack of a better word.
Oh yeah, because I know it's a very big argument on people who are seeking out detransition or who are regretting their transition. I know that's a somewhat controversial thing, and there's a lot of people I've even seen just in the few people I've just observed on the topic. They are, you know, some of them are being somewhat neutral about it. Some of them not so much.
I I've seen, like a lot of like negativity towards people who tell about their detransitioning stories as if they are like quote unquote betraying their quote unquote kind. These are horrible stories what I have read online about people that these are extremely vulnerable people, just like people suffering from gender dysphoria.
Oh yeah, it's a very complex issue, and I feel like there's multiple ethical pieces to it. Like I was saying, kind of a little bit before you jumped on the stream, was you have the situation now where Arkansas has made it illegal for anyone under the 18 to get basically any medical transition care. So if you have a different age of medical consent in the state for other things, so just say any other procedure, say it's 15, you can consent to most medical procedures at the age of 15, for example.
Mm.
Now you have a different standard for access to healthcare for specifically transgender people. Or, for example, I don't know what the age or the requirement is for being able to have an abortion in the state. Are underage women getting access to that kind of care? Is it fair and ethical to allow them different access to health care?
That is a very hard question. Again, I'm not sure what the like. I'm not a medical professional. I'm not a psychologist or therapist, so I can't really tell what's the quote unquote right thing to do when it comes to uh, people seeking a transition when they're under 18. What they would require is like at least what you described, 6 months of therapy to get to know
Okay.
that person, that if they even have the prerequisite mindset, so to speak. I don't speak therapy, but you probably
So
know what I mean.
I understand what you mean. So I would. It's not necessarily you need 6 months of therapy. You have to show at least 6 months of having those symptoms, of
Yeah,
having the
that's what
symptom.
I meant.
Okay.
Like,
Yeah. So I can see you once and be able to establish that you've had those symptoms for years. But it's not necessarily the case of you have to see someone for that long of a period. I think that was probably part of the reason they may have changed the language between the versions, is maybe there was some confusion there. I haven't been able to research a lot into the history of all the different ones. But with that, do you have this, is it fair to even prevent people from accessing it now? Are you causing, there is an ethical argument of, are you causing harm by not allowing people to have unfettered access to being able to transition at their own pleasure and at their own will? Should a person be able to make that determination, adult or child, regardless of age? I think that's a piece to factor in.
I mean, there's a lot of moving parts. Like, as a society, pretty much globally, we have decided that people under 18 don't have the capability to make a lot of choices for themselves due to maturity and all that.
Yeah.
I'm
So,
sure there are a lot of people under 18 who are much more mature than people who are 18 and up.
yeah, I need to answer a phone call real quick. Can I? I'll be right back.
All right.
Okay, sorry for that. I am back now.
Welcome back.
So I had to take care of something real quick. So, like I was saying, this is a such a multifaceted issue. I don't know if there's a correct answer that can be actually given in like a sentence or two or even a paragraph because of just what is going into it. But my goal with this was to basically communicate the information at the bare minimum, show people that the standards do exist. It's not just a willy-nilly access you know, to hormones and to all this other shit. You do need certain levels of treatment. You do need to be show that you are able to manage some of the stuff you've got going on. You can't just be a complete fucking mess and get all this care. You need to be able to take care of yourself in a lot of aspects before you can move forward with some of this other care with like hormones or puberty blockers or surgery. So I hope that for not only yourself but anyone who was able to watch or who listens to the show, both this episode and the last one were to some level helpful. Again, you know, I don't pretend to be an expert on this. I'm using what level of information I have from, working with some people in my practice. Uh, the information I've done, because I did some research while in grad school on this, in as far as the origination of gender dysphoria and the first like transgender surgery and how we got to where we are now. And I think it's a very important issue because it's one that's kind of at the forefront of society. And so I think the more information out there, the better. But I guarantee you that this stream would be considered offensive to a lot of people because they would not like what I'm having to say right now. And I hope that people will open their mind to some of these things and realize that it's not just a yes or no to all of this. You can't just say one thing or the other. There's a lot of nuance, and sometimes case by case is the way we do mental health. So,
It is very worrisome that it has been made in a black and white issue. Either you are all for it or you're not for it at all.
and it's sad too. It's really sad because it prevents us from really truly getting an answer to the question and finding the best way to deal with it moving forward.
Mm. I mean, it wasn't like a couple of days ago I was called a bigot because I did not 100% support the new law that's being proposed in this country.
What was the law, if I may ask?
It's the trans law that allows people under 18 to have more autonomy over their gender identity legally and access to uh, trans care when it comes to puberty blockers and such.
Okay, so that's interesting. So it was a pleasure to get to talk to you. I know you were busy earlier, but thank you for taking the time to jump on now. I have some obligations I have to take care of here, so I'm going to have to go ahead and wrap up the stream a little bit earlier today than I might have wanted to. I know my last stream was at least 2 hours too, so this is like a 4 hour discussion on just this topic. So I appreciate anyone who showed up today, who popped into chat, who engaged in this video. I've been trying to keep an eye on my watch metrics, the analytics, to see if people are actually interested in this. So I'm continuing to kind of figure out what to talk about, ways to grow my channel here. I'm going to try and do some of those YouTube shorts, I think, related to maybe specifics of like mental health conditions or maybe fun little facts or maybe unique odd things, or maybe use them as ways as like teasers for longer videos or streams. I'm going to try and do some short content, trying to set aside time at work in between clients to maybe record short stuff, maybe not streams, but just to record something. So I do have things in the works. I do have a bunch of ideas written down on what I want to do. And I'm always open to suggestions. So if you have a topic or an item you'd like to comment on, or if you're interested in coming on to the show to talk about something, whether it's about yourself or about a specific topic, if you have information or you have experiences, again, I'm a counselor, I'm a therapist, so I talk professionally in my day job. But again, if I haven't didn't do my disclaimer, I'm not your counselor, I'm not your therapist. Seek out a professional for your own problems. But if you want to come on here and share what you've had to deal with, what you've had to go through, any struggles, the ways you've been able to manage things, I'm willing to talk about anything. I'll talk about the shit most people won't talk about because it's horrific. I was in, for example, Nick's Discord the night before, and it was like 1 a.m, and I had just read the story about the 18-year-old girl from the United Kingdom who had left her 20-month-old child alone for 6 days to starve to death while she went on a bender for her 18th birthday. And it just hit me to the core. Like, it was so fucking depressing. So sad to picture what that was like. Because a 20-month-old kid that's almost 2 years old is now, potentially wandering around their house looking for their mom, crying, screaming. Like, that's a lot. That's pretty fucking heavy. And just picturing that was a lot. That was too much in that moment. Because I've dealt with my own, for example, fertility issues. I haven't been able to have my own child yet. But you watch something like that, it's a very difficult thing. And that's just something, this isn't even the worst. I'm open to talking about anything, abuse of any kind, um, things that most people wouldn't be able to listen to. But, there's a few things that even throw me. That story was one of them. So, but any final, sorry for the diversion there for a moment, but any final comments for me today or for the stream today?
No, not really. Always a pleasure to talk with you.
It's always a pleasure to have you on. I hope to have you on again for another full show, hopefully in the near future. Just hit me up when you're available or what your rough availability is, maybe, and I'll try to work around that. Um,
Yeah, absolutely. Going to school, so it's I just need to pick out all the school days off.
oh yeah, it's a pain in the ass. School was always fun, but
Yeah, especially when the schedule keeps moving around because of COVID and because our government can't decide on COVID restrictions. So it kind of puts all things in a little bit of chaos here, but it's slowly getting into more that I have a more solid schedule, so it doesn't change every Friday like it has for the past few months.
well, that's good. Hopefully, like you said, kind of calms down a bit and makes it a little bit easier to manage. But thank you so much for showing up again today. Thanks again to the stream for being here. You guys are, even with 3 or 4 people watching, it still means a lot that 3 or 4 people are willing to take the time out of their day to listen. So I will end with that. I wish everyone a great rest of your day. And again, if you ever have any questions or comments or thoughts, you could send them to my email, which is in my YouTube channel in my About section. Hit me up on Discord, um, in a private message. My Discord channel is almost fully set up, and I'm working on finishing up my locals, hopefully, is a potential way to help allow me to focus more time on this because I can see less clients, so I can work more on this shit. So, but like I said, with that, again, I wish everyone a great day. Take care of yourselves, take care of your friends, family. Make sure, if be that person someone can call when they're not doing so well, because you never know that day you'll need it yourself. And you'll be surprised at how much more impact you can make than even someone like myself can. Just being there for friends and family. You guys, you as a person are the front line of defense, because you guys are able to make things better when it's a lot smaller of an issue. Usually if you're getting to me, the issue's gotten to be significant. You know, you don't have to be an expert at it. All you got to do is listen. So, with that, thank you for listening. Have a great day, everybody.